Good morning, everyone. Thank you all for joining us this morning. It's my pleasure to introduce Gregg Fonarow today as the Samson visiting professor. I had prepared a couple of slides, which we're not going to try and complicate this morning's AB presentation with, but if you come to Medicine Grand Rounds or Zoom in, you will see the slides. Essentially, for those of you who have come to the University of Washington since Werner retired, Werner was one of the two original faculty members here in the division back in the 1950s. So Bob Bruce was recruited from University of Rochester in 1950 to form Cardiology, which was all on one floor up at Harborview. He recruited Len Cobb and Werner Samson as the two, and they took the first divisional picture back in the 50s. We don't know exactly what date. And it was going to be such a sad division picture with just the three of them. They then grabbed just random people. And so when you see, no one's able to identify the other folks. But there's also a picture of Werner and Joan. And I just want to thank them for being such, Werner for all his years of contributing to the division, but also now supporting things like the Samson visiting professor, where we can bring in leaders and friends from around the country. And this is actually, I think, the first in-person Samson speaker we've had since COVID. So, and thanks, Gregg, for doing this, and thank Joan and Werner for also hosting a very nice dinner last night. Gregg. I actually met Gregg. I was doing the calculations last night, 25 years ago, which made me a little sad. I came to UCLA at the time. Gregg was already an associate professor, and I joined him, and it was he and I were the academic heart failure section at the time. But I was a basic scientist, but I was always impressed with Gregg because he really sort of led the division in terms of our clinical programs. If you get a chance to talk to him, you will find he has an encyclopedic knowledge of trials and everything clinical. And the thing that really impressed me wasn't what he was doing in heart failure, but the fact that he's able to do heart failure and then be on writing committees for atrial fibrillation and atrial flutter and all of this very diverse. And then if that wasn't enough, Gregg was one of the early sort of champions with the American Heart Association's Get With The Guidelines. And we were doing that at UCLA long before you had to pay a membership to the American Heart Association to participate. So I already knew what it was long before it sort of came out. And Gregg was instrumental in all of those. And he's really made this wonderful career in doing quality and outcomes research. And anyone who wants to make a career in quality and safety in the cardiovascular space, I would recommend they try and get a few minutes of his time to sort of chat with them. He's been so successful. The AHA Council on Quality and Outcomes recognized him 4 or 5 years ago with their Lifetime Achievement Award. And then recently he received the AHA's Golden Heart Award, which is they give their highest award for volunteerism, which I think in large part was related to his championing of the Get With The Guidelines. My favorite part of Grand Rounds at UCLA was the two that Gregg gave every year. He ran Grand Rounds for I don't know how many years, and I think that was one more duty he dumped on me at some point for my career development. Was after all the major meetings, the AHA, ACC, he would summarize the clinical, late-breaking clinical trials, but anything new clinically. And what I think separates him from many people, he doesn't just report the results. He understands them, he puts them in context, and he analyzes the results. And I think that's what separates Gregg from many others in that you will hear. And so I'm, of course, looking forward to his talk, which is going back to his first love. But I realized Julie was important here. Improving quality of care and outcomes for heart failure patients. Thanks, Gregg.
So thank you, Rob, for that very kind and personalized introduction. It's really a pleasure to be here in person as a Samson lecture. And hopefully we can get the slides actually broadcast soon on the screen, so you're not all having to log into Zoom to see that. But I'll be presenting on improving the quality of care and outcomes for heart failure. And so, see if we get to.
Yeah, it's over here. But...
We actually spent a half hour trying to get this set up, and it was working. I don't know why we got to a blue screen. So maybe I should be telling you stories about Rob when he was at UCLA, or maybe not. But I'll tell you a little background while we're waiting, actually, on the interest here and how this actually evolved of really feeling like when we get new trial evidence that we should really try and translate into practice. And it was when I started off as a heart failure fellow under Werner Stevenson, and a trial had been done at UCLA that was comparing hydralazine, the direct vasodilator with isosorbide dinitrate, and ACE inhibitor captopril. And at the time, there had been the VHAF study that showed perhaps some marginal benefit with direct vasodilation in this hemodynamic hypothesis for heart failure. And there was a study done in Europe looking at ACE inhibitor in poorly defined patients, but showing an effect. And there was this debate, should we use neurohormonal antagonism versus direct vasodilation? My first assignment that first month into fellowship was to analyze single center double-blind trial that had been 159 patients. And there was just this striking mortality difference in advanced heart failure. 49% one-year mortality rate with hydralazine nitrates and 19% with captopril. So huge difference. This is before the VHAF2 data came out, so nobody else knew this answer. Quickly wrote it up as an abstract, drafted the manuscript. But we also had all of these patients that we were following that, a lot of them were on hydralazine nitrates because cardiologists tended to prefer that, easier to use, didn't have bumps in creatinine or renal dysfunction. And so we thought, oh, got this result. We need to, quickly get all our patients in or even call some up and make this change. And that mortality difference was so striking within a month or two, it became pretty clear to the small little group of us, we were seeing lower monthly mortality rates in these patients. So here was this trial result coming available, translating to practice, which was easy because it was just me as fellows calling up Hamilton and Warner and Stevenson, making this shift and having this discernible aspect on outcomes. Now, obviously, with our therapies now, you're not going to see that kind of like in 2 or 3 months, this notable difference. But we had a database and registry, and we're able to show actually looking at that error from pretty much hydralazine nitrates, a little bit of captopril, randomized patients to that next period of time of preferentially using ACE inhibitors, of seeing the improved survival with regards to patients. So it really solidified in my mind, if we could take our evidence and potential, local or national guidelines and translate that into clinical practice, that you can have a discernible effect on outcomes. And so with that got me really interested of like, how can we do that on a larger scale? And how can we do that not just in heart failure, but across cardiovascular disease? And so with that all in mind, it began, this interest in what, has eventually gone into implementation science, into quality care and outcomes research at a time that wasn't really thought to be kind of a direction that you could go, or a field that could get grant funding or otherwise. So that's a little background that hopefully we'll get to being able to actually display these slides. But
Don't let Greg convince you
Yes.
that every intervention went smoothly. I remember when we had all the dilated cardiomyopathy patients on staff.
so there are times that we jump the gun on things.
Can't see. Why don't
What we
you-
do.
So we can see them on Zoom, but not here.
Okay, so
Wanna
should we,
progress ahead.
everybody
Pull your
log
phone
onto
up.
your screens and we'll go? Okay, so to those on Zoom, sorry for that delay, but we'll kick this off. So with that in mind, improving quality care and outcomes for heart failure, here are my disclosures. What I want to highlight with this slide is heart failure is common, costly, and deadly. 6.7 million men and women with heart failure, million new cases, 415,000 deaths. As I'll show you, we have a number of evidence-based guideline recommended therapies that can markedly improve outcomes, but the vast majority of patients are not on one or more of these therapies, and as a result are having clinical events that could have been prevented. And so really the key message of this talk is greater therapeutic urgency is absolutely needed. Now, here's data we generated from Get With The Guidelines, linked to Medicare data, and looked after new onset heart failure. What is the median survival? And compared to age and sex matched individuals of similar age without heart failure in the US. And what you see is over a 15-year loss of median survival occurring. And this is regardless of ejection fraction. And even for individuals age 90 developing heart failure, 4 years of loss of quality of life. So I don't think anybody can look at these recent statistics and not realize the outcome for heart failure patients needs to improve. There's huge loss of life for patients. Now, do we have any therapies that actually can improve outcome? And as you can see on this slide, there are actually a number of therapies that have been tested in randomized clinical trials of patients with heart failure with reduced ejection fraction and have been shown to be so powerful. They don't just alter symptoms, don't just alter hospitalization or event rates. They have the power to actually reduce all-cause mortality. And the relative risk reductions here ranging from 17 to 42%. And in absolute terms, mortality reductions where we're seeing numbers needed to treat to save a life over 36 months in single digits, where you're extending median survival by 1 to 3 years with each of these individual therapies, as well as getting improvements in symptoms and reduction in hospitalizations. So what you should now expect to see is these therapies became available and were integrated in the guidelines, the improvement in outcome for patients with heart failure in this time period. But here's data looking at 1, 5, and 10-year outcomes after the availability of these therapies, after being recommended in guidelines. And yet you see why there are these slight improvements, nowhere near as large of the reductions that we would expect for this patient population and in this time frame, in this very high 1, 5, and 10-year mortality rate. So despite the availability of these agents, we've not seen the kind of improvement in clinical outcome that we would expect. And not just in the US, this is data from the UK and similar data from across the world. So how do we explain this? Does this mean these therapies really only work in select patients enrolled in randomized clinical trials? Is it that somehow clinicians weren't convinced, or they were convinced but not implementing? And so to really understand that, there's been a series of studies looking at in clinical practice in a whole variety of settings, what are the utilization of these evidence-based therapies shown to reduce mortality in randomized clinical trials, and looking just at eligible patients without any contraindications or intolerance. This is data from CHAMP-HF. These were cardiology and multi-specialty practices. And the bottom line answer is there is some use of ACE inhibitor or ARB and beta blockers, about 2/3 of patients. But when we look at newer therapies or ones that have had little issues come up, use of sacubitril/valsartan, in the time frame, it was already class 1 in the guidelines, only 13% of eligible patients. MRAs that were, the Rawls trial, 1999, here we are almost 2 decades later, only 1/3 of perfectly eligible patients. Then when we looked at, well, how were they dosed? The vast majority of patients were on low starting dose with no attempt for up titration. And when we asked the simple question, well, for, triple therapy, what percentage of patients are on all 3 in a target dose in the guidelines? It was 1%. 1%. In the absence of contraindications or intolerance. And we've seen this in other settings as well, outside of highly specialized heart failure clinics. So there's huge, huge treatment gaps that exist. This is data on this slide from the ACC Pinnacle Registry. This is an EHR-based registry, over 6 million outpatient heart failure visits, over 8,000 clinicians, 724 US practices. These are all heart failure reduced EF patients, ACE inhibitor B missing in 1/3 of patients, beta blockers missing in 1/3 of patients, MRA is missing in 3/4 of patients, sacubitril/valsartan use less than 1 in 10 patients in the time frame that these were evidence-based and in the guidelines. So we're seeing this on a very large scale. So what are the reasons for underutilization of evidence-based therapies? Certainly there's some knowledge gaps, may not be aware of the actual trials and what the guidelines recommend, but so much more of this is lack of systems. There is a very strong, and I'll show you data that supports this therapeutic inertia. The clinician strongly believes they're going to do it and provide that therapy, but each and every visit, it gets deferred to the next visit, and never happens. There's also a misperception of risk, and I'll highlight that. There are legitimate questions about when the patient in front of me that may be older, more frail, more comorbid conditions, do the clinical trial results really apply? So will the efficacy translate to effectiveness? There is an overt and over concern about adverse events and side effects, and I'll try and address that. There's some biases that are based on the patient's age, sex, race, ethnicity, or socioeconomic status that they're not treated, and legitimate concerns about access, cost effectiveness, and value of it, particularly some of the newer and branded therapies that also need to be addressed. So can we look a little further in this, and will it point us in directions of what we can do to actually improve upon this circumstance? So this slide shows longitudinal data in CHAMP-HF. So there's heart failure reduced EF patients are being followed over time, 12 to 24 months, looking at each of the visits, what medications they're on. And over this time period, and no matter how symptomatic the patient was, whether we're intervening hospitalizations, what we saw is visit after visit after visit where they weren't on a therapy they were eligible for and it wasn't started. Visit after visit after visit where they were on low starting dose and there was no up titration of medication. So we have this situation where this is overwhelming clinical inertia that's very difficult to explain. It's as if the clinicians seeing these patients are perceiving them to already be adequately treated and so low risk, no changes in therapy were actually necessary, despite the fact these patients did go on to have cardiovascular death and events. So this is a figure from a perspective piece we had put in JAMA together with Javed Butler and Steve Green, and was just highlighting if you compare to atherosclerotic cardiovascular disease, our perception of risk, and the very high risk group, the group that guidelines would say you need to pull out a PCSK9 monoclonal antibody, and aggressively treat these patients. That risk pales in comparison to the most mild, stable, however you'd want to describe heart failure patients. So if we're going to be on the same lexicon, we need to view those patients as extreme high risk and those with the recent hospitalization, more advanced heart failure as very extreme high risk, to have that better alignment. And so because the clinical risk is underappreciated, theory at least, medication changes are deferred, time is lavished, and patients go on to have clinical events that could have been prevented had there been better perception of risk and more therapeutic urgency. Now, the other thing that I would put forth is going on, this is a little difficult to study, but reflects the patterns, which is that many clinicians seem to perceive once you've got one or two medications on board, that's sufficient. And that any subsequent medication is somewhat redundant or maybe only partially additive and you're in diminished returns. But there doesn't seem to be this perception that each of these therapies are truly additive to each other. So what I'm now going to do is spend a little bit of time to see if we can convince you that these therapies truly are additive or worthwhile, that utilizing the full set of mortality-reducing medications is evidence-based and absolutely worthwhile for patients. So if we go back to one of the original trials, consensus with I mentioned in the introduction, but then solved and saved, we had data for the first time that you could alter the natural history of heart failure with ACE inhibitors and reduce all-cause mortality. So ACE inhibitors on a background at the time of diuretics could clearly improve clinical outcome. And the next series of studies then looked at beta blockers. And the background rate of ACE inhibitor or ARB use was in the mid-90s. And the incremental benefit of now adding a beta blocker is we got further mortality reduction. In fact, not on the order of 20%, but 33, 34% relative risk reduction mortality. And this was replicated again and again in US Cardiology, CBIS-2, Merit, Copernicus trial. So clearly an additive benefit, clearly a magnitude of benefit that was large enough, robust enough that it was clinically meaningful. Now, what about MRAs? The first MRA trial done where it was on a background of ACE inhibitors, beta blocker trials were just getting started at that time, and we saw a large reduction in all-cause mortality. But emphasis HF is now on a high background rate of ACE inhibitor, ARB, and beta blocker, and we truly get an additive benefit, again, with regards to all-cause mortality. 1 + 1 + 1, truly equaling 3 in that magnitude of efficacy in our randomized trials, and that triple therapy being better than double, and that being better than single therapy. Now, the next therapy that was looked at was not compared to placebo, but was compared to an ACE inhibitor, and this looking at the incremental value of neprilysin inhibition using sacubitril/valsartan, the angiotensin receptor neprilysin inhibitor, with a high background use of beta blockers, high background use of MRAs. So we're truly looking in the control group on the ACE inhibitor, and sacubitril/valsartan gave us an incremental reduction in the primary composite endpoint CV death, and importantly, all-cause mortality. So now we have that addition of neprilysin inhibition to that regimen, that fourth drug or fifth mechanism giving us this additional incremental benefit. Now, was this large enough and worthwhile enough? You can see in this slide the cardiovascular mortality reduction with an ARB or ACE inhibitor alone, angiotensin receptor neprilysin inhibition doubling up on that cardiovascular mortality reduction. So this incremental benefit and clearly worthwhile and additive. Now, importantly, and this is really a tension between population health approach and a precision health approach. Because the precision health approach would say, well, let's find among this population treated in the randomized trial, who was that subgroup? Who were those patients that would precisely benefit from sacubitril/valsartan, and those patients better off on the ACE inhibitor? But across 64 clinically relevant subgroups, you could not identify a subgroup of patients that were better off being left on the ACE inhibitor. Sacubitril/valsartan, that addition of neprilysin inhibition, offered additive benefit. And that was true in our beta blocker trials. That was true in our MRA trials. So we're seeing this population-based approach, additive incremental value, clinically meaningful benefits, and at least through the subgroups, comorbidities, baseline labs, not able to discern some subgroup better off without that treatment in the absence of absolute contraindication. Our next class of therapy was discovered by serendipity, the SGLT2 inhibitors being studied for cardiovascular safety, this remarkable reduction, heart failure hospitalizations and EMPA-REG outcome, 70% reduction heart failure mortality, mechanisms still being worked on. But that clinical observation quickly followed in other trials where you were seeing this benefit and raising the possibility that beyond just in type 2 diabetes, could this actually be a heart failure treatment? And so there are a whole variety of mechanisms that were speculated why in the absence of diabetes, SGLT2 inhibitors could be beneficial. And this was taken rapidly to a randomized clinical trial, DAPA-HF, close to 5,000 patients on other standard background therapies at the time, randomized with or without type 2 diabetes to dapagliflozin 10 milligrams once daily versus placebo, standard of care. And what we saw in this trial is this significant benefit. Primary endpoint, CV death or hospitalization for heart failure, urgent heart failure visit, 26% relative risk reduction, NNT 21, highly significant, and on a high background rate of triple therapy, ACE, ARB, or ARNI, beta blocker, MRA. So truly incremental benefit. The benefits were similar, whether type 2 diabetes or not, no significant interaction. This was true regardless of across all of these clinically relevant subgroups, regardless of etiology, race, ethnicity, region of the world, regardless of renal function, whether you had type 2 diabetes, severity of heart failure, background natriuretic peptide, AFib, yes or no, and truly additive, regardless of what background therapy you were on, and importantly, additive to sacubitril/valsartan. So again, incremental benefits clearly being demonstrated. Importantly, safety and tolerability compared to placebo as well or better tolerated. More serious adverse events on placebo than on medication. And things people worried about, diabetes, ketoacidosis, very rare, not seen in those without type 2 diabetes, no major volume depletion, amputations, hypoglycemia that people worried about giving it to patients without type 2 diabetes, not seen. We also had Emperor Reduce pulled the two trials together, a convincing reduction in all-cause mortality, and again, across all the clinically relevant subgroups that we're seeing. So now moving on to essentially quadruple therapy improving outcome. So here we're really putting together and conveying, look, in absolute terms, you have heart failure reduced EF in the absence of any therapies, 35% 1-year mortality. The incremental benefits as shown in these trials truly add up. And if you look at that 2-year mortality rate now on full quadruple therapy down to 9.1%, that is a 74% relative risk reduction, a 26% absolute risk reduction, and NNT to save a life in 24 months of just 4. Think about all the things we do across cardiovascular medicine. Very few things get even close to that. But now the question becomes, okay, the data is here. It's compelling. Every national, international guideline have these class 1 recommendations. But how should we go about actually applying this therapy into practice? And you could take an approach of, well, let's just follow the randomized clinical trial data and use the historic sequence. Start with an ACE inhibitor ARB, up titrate, and only then start your beta blocker, and only then start your aldosterone antagonist. And once on those therapies, then switch over to sacubitril/valsartan. And after all that, then add the SGLT2 inhibitor. Sounds great, evidence-based, following the trials. But what does that actually mean, and do we have the time? So here, if we map out what following each of these steps would mean, and if you did this perfectly and at 2 to 4 week intervals, it would be 28 to 56 weeks till guideline-directed medical therapy was fully implemented. So are the therapies so slowly acting that we have this time? But it's actually a little worse than this, right? We don't see patients back at 2 week intervals. We often see them back at 2 to 3 months. So now if you map that out, we're starting to talk about, well, 14 different follow-up visits over 3-month interval. Wait, it's going to be 3 to 4 years before we get guideline-directed medical therapy fully initiated and up-titrated. And that's assuming no clinical inertia, that on every one of these visits, a change is made. So that just sounds like absolutely disastrous. But that's what's happening in clinical practice. That explains how at 24 months after a patient newly presents with heart failure reduced CF, only about 1 in 10 patients is on triple therapy. And it's getting trapped in inertia and following this historic drawn out pathway of going slow forever and never getting there. But do we have that time? So what's the timing of the benefits of these therapies? And it's unbelievably rapid, and it's largely been overlooked how fast these therapies work till very recently. This is data going back to Copernicus. So severe heart failure patients randomized carvedilol versus placebo. 2 to 3 weeks, the survival curves are diverging. Your risk of worsened heart failure in the first 8 weeks is higher with adding placebo than adding the beta blocker therapy. This is data from Emphasis HF. It's actually day 19. These event curves diverge and become significant statistically. 30 days, highly significant in matching the benefits over the course of the trial. Again, even in mild heart failure patients with MRA. Here is data we have from Pioneer HF, hospitalized with heart failure, de novo or worsening of existing heart failure, randomized within 24 hours of the hospitalization, the ACE inhibitor enalapril versus sacubitril/valsartan on the background therapy. And look how early in days these event curves are diverging. Overall, 42% relative risk reduction, 6% absolute risk reduction, highly significant by day 30. So again, we're seeing this early and clinically meaningful benefit. This is true for new onset heart failure. So guidelines of start first with an ACE inhibitor at 8 weeks, switch over to sacubitril/valsartan never made sense, but here's evidence showing they really don't make sense in that regard. And further evidence, because in this trial at 8 weeks, patients randomized to enalapril were converted over to sacubitril/valsartan, but you see they never catch back up. So those earlier events that could have been prevented with the better therapy started right off the bat weren't prevented, and you couldn't, switching later, ultimately catch up. So delaying initiation of one or more of these therapy leads to preventable events. This is data for SGLT2 inhibitors, remarkably fast. You can see the event curves within a day actually start to follow. It reaches statistical significance sometime between 14 day and day 28. But this magnitude of benefit. We see with SOLACE, which was worsened heart failure started in hospital, often pre-discharge or immediately thereafter, within 30 days of randomization, large clinical benefits. And also health status. And the IMPULSE trial specifically started early within 24-hour SGLT2 inhibitor in heart failure, and you got event reduction. So significant, clinically relevant event reduction very early on with each of these therapies. So if we're going to think de novo, what should our strategy be when a patient presents in the absence of contraindications, cardiogenic shock or otherwise? Why not get all 4 of these therapies started simultaneously? Could that be well tolerated? With this overcome inertia? Straightforward in that regard. So have put this forward, been doing this in clinical practice, makes a lot of intuitive sense, then focus on more rapid up titration of these patients. And once on foundational therapy, can then focus on comorbidities, device therapies, other things that may be needed. Beta blockers obviously have the steepest dose response curve way to do this. Not comfortable starting all four simultaneously, fine a day apart. But the key is getting in very rapid time frame all four of these therapies started. Why? Because delaying one or more is leading to events that could be prevented. So what are the additional benefits? Well, rapid improvement in health status, rapid improvement in EF, to where many patients who otherwise would have needed an ICD or CRT, EF's now above 35% may not. 30-day rehospitalizations, which is a national reporting metric, going to look great on that, and the rapid reduction mortality. But the other key thing is you overcome inertia, get far greater adherence in patients, more likely to stay on medications longer term, and thus benefit from them. So first, since we first put this forth, there have been a whole number of viewpoints, other algorithms, all of which are focused on rapid initiation. Some may go 2 by 2, some 3 by 1, some, few days apart, or personalizing for patients. But what they all have in common is trying to get therapy started very quickly, rapidly, and very short titration schemes to get the maximally tolerated GDMT, recognizing this early benefit. Here's a modeling study that was done to look at what would give you the very best outcome, looking at all the different sequences and basing this on the randomized trials. But of course, the scenario that gave you the very best outcome was starting all four simultaneously. Here's another kind of algorithm highlighting how you can do this within 4 to 6 weeks, be up on full target doses, and you can see the early relative risk reductions that can be achieved. Now, you may be thinking and legitimately worried, well, what evidence do we have of actually starting these meds with regards to tolerability? And so it's interesting to look back at the blood pressure effects at starting dose of these meds in the randomized trials compared to starting placebo. And what you see is, from a blood pressure standpoint, very well tolerated. If your blood pressure starts off on the lower side or normal, you see very little change or even an improvement. Those that are overtly hypertensive get a reduction in blood pressure, but that's desirable. Sacubitril/valsartan may be a little more symptomatic hypotension, but it's modest. But the other ones, incredibly well tolerated from a blood pressure standpoint, 1 or 2 millimeter difference. Now, the other thing is, well, what about other adverse events? Aren't you going to make them more frequent? Well, it is totally true. You start one of these GDMTs, and within a week, patient may have some adverse event. And of course, what do we think? It's due to that therapy we started, of course, very legitimate. But in this study, we looked back at the randomized trials and looked at the adverse events as reported by investigators that they attributed to study drugs, so a treatment-emergent adverse event, and found the rates of that were identical between placebo and the study medication. Now, that's not saying medications never cause side effects. They can. That doesn't mean some of the background therapies weren't contributing, but a lot of this is the underlying disease state, or maybe over-diuresis or other aspects. But we need to be more circumspect about stopping a med for a nuisance side effect that's mortality reducing. Doesn't make sense to increase the patient's mortality rather than try and manage that side effect, or to delay a therapy that's life-saving just because you think hypothetically maybe it would make it better tolerated when we don't have any evidence that a drawn-out sequence makes therapy better tolerated. Now, what about the concerns about older patients? It's true, some of the randomized trials early on did not enroll older patients, but our more recent trials did. There's excellent representation of those above 65, those above 75, and the efficacy is every bit as large. So this concept of polypharmacy in our older patients, totally legitimate about medications that are not disease modifying or life-saving, but clearly need to do more. We have real world effectiveness data, beta blocker, sacubitril/valsartan, MRA, in patients age 80 and above, and seeing these improvements over time in clinical outcomes and survival. Now, you will get some bumps in creatinine and drops in GFR. So what does that mean? Is that renally damaging? Here's data looking at SGLT2 emitters. No, they're renally protective. they're indicated in chronic kidney disease. That little drop in GFR, the slopes end up crossing, you get better outcomes. And in fact, in this provocative analysis of DAPA-HF, those patients that had the acute eGFR decline with the SGLT2 inhibitors had a 27% reduction in the primary endpoint for hospitalization CV death. It's an evidence they're working. Now, you have a decline in GFR, just, in diuretic and background therapy, that's associated with worse outcome. But these drugs, whether sacubitril/valsartan, SGLT2 inhibitors, clearly make things better. We have a lot of data. If you withhold a medication or discontinue it in the absence of contraindications, you get worse outcomes that persist, even if you restart the med. But, that's not the same as, I want to see direct data. Fine, starting all 3 or 4 of these meds at once, safe, tolerated, improved outcome over usual care. So we now have the STRONG HF study. Now looking at quadruple therapy, SGLT2 inhibitors weren't included, but triple therapy was. And the high intensity care arm started early in hospital, up titrated to 50% of target dose prior to hospital discharge, see the patient back on week 1, week 2, make sure they're tolerating meds, continue up titration by week 3 post-discharge, try on full contingent of triple therapy, and then continue monitor patient. First, usual care, start what you want in the hospital, see patient and follow up, and up titrate. Study stopped by the Data Safety Monitoring Board due to overwhelming benefit. So here's looking at high intensity care versus usual care for full dosing of triple therapy. And you can see here for ACE inhibitor ARB, ARNI, marked different. Now, does everybody get on target dose? No, but a substantial portion does, and way more than usual care. So you can improve GDMT with this type of approach. What about safety, tolerability, side effects, and otherwise? Actually, blood pressure, reasonably well tolerated. GFR, very slight change, didn't reach significance. Patients' congestion status improved, though. New York Heart improved. Biomarkers got better. And importantly, for clinical events, there is, this absolute risk reduction of 8.1%. 8 per 100 treated, amazing, and 34% relative risk reduction, highly significant, quality of life scores improving. So we can see we can do this practically. This was done in mid-tier and lower tier economic countries. So, to say, wow, in the US, the idea of seeing patients back after a discharge is too high tech for us. That doesn't make a whole lot of sense. Here's some tips for optimizing GDMT. But what is so important is that focus of getting the therapies on, managing any potential side effects without giving up the therapy unless there's an absolute contraindication, and removing any of the barriers to adherence, persistence, addressing cost barriers, and making the patients realize each of these therapies work together, no overlap, are truly additive, and more meds does not mean the patient's worse. It means they're getting better and towards recovery. So here's a slide that we've used different versions on, this from an editorial, Steve Green and I, but really highlighting, to not just be concerned about, side effects and adverse events related to things we do, but think of the risks for patients of omission that by not starting or titrating GDMT, that reduce survival, the increase in hospitalizations, the worse quality of life and worse symptoms our patients experience. And so every encounter with a heart failure patient in every setting is an opportunity to overcome this risk of omission and achieve better outcomes. And here's a slide that actually quantitates the magnitude of that risk. And further, the cumulative benefits early on for hospitalization mortality as well as longer term are profound. Now, if you look at the guidelines, right, they've embraced this approach, right? It's start all 4 of these therapies and get them on. Here's the ESC guidelines of, focus on the therapies to reduce mortality and start them fast. And in the 2023 update, take the STRONG HF trial and give a class 1 recommendation for this high intensity approach for starting GDMT. So again, all these therapies, there's not a debate, they're class 1 level of evidence A It's really about getting them started. Yes, there are other therapies that may be additional ones after we've optimized GDMT, but many of these will not be necessary if you get foundational therapies started early. Now, I want to further highlight this issue of once that patient leaves the hospital, what happens to them? This is from Connect HF, and the focus was from time of hospital discharge through 12-month follow-up, and a dedicated quality improvement program using all the kind of best practice techniques. And what we found was for GDMT and dosing, the median change in their performance score from time of discharge to 12-month follow-up, these were volunteer sites and clinicians, was zero. Zero, no net change. So it is so critical prior to discharge to have a safety net of those therapies you think that patient's going to be able to rely on for the next 12 months. Now, here's other evidence. You start therapy in hospital at 12 months, far more likely to be treated than if they're not started. And many of these patients were tried outpatient, not adhered to, or discontinued. So in hospital initiation, more likely to be treated, more likely to persist on therapy, adhere, feel better, more likely to be home, more likely to survive. And unfortunately, go slow doesn't mean more cautious, careful, thoughtful physician. It means rarely initiating these therapies, rarely titrating them, and patients having events that could have been prevented. There are other strategies to improve therapy, multidisciplinary heart failure disease management programs, navigators, GDMT clinics. These performance improvement programs can work to improve care, prompts in the EHR. But here I want to show you, we put forth like quadruple therapy should be the goal, time to GDMT, quadruple foundational therapy. And we put that forth, 78 centers in a pilot for AHA's Implement HF, and getting the clinician, yeah, all these other aspects are important, but focus on quadruple therapy. And what we found is, with time of discharge, their baseline probably a little better than the nation, 1 in 10 patients on quadruple therapy. But within 2 quarters and with this focus, a discharge and a 30-day follow-up, close to half. Now, shouldn't be 100% of eligible patients, yes, but pretty rapid uptake and implementation with this approach. So want to really just highlight in taking the final kind of question, well, what about cost? Here's formal cost effectiveness, high value with these therapies. Here's actually looking at the strong HF approach and finding it's only about $5,000 or $10,000 per quality adjusted year of life saved, giving the large magnitude of benefit. So from an economic and value standpoint, this makes a lot of sense. This slide highlights, though, this tremendous difference in perception between oncology, cancer, and heart failure. You get a new therapy on oncology that extends median survival by 3 months, and it is touted as the most phenomenal breakthrough, standing ovations, even if it costs $250,000 a year. And there's rapid, widespread adoption. It's not even an issue. They don't need these quality improvement studies because it's like uniform. Heart failure, you get a new oral therapy that extends median survival by 1 to 3 years, well tolerated, none of those horrible cancer side effects. Price, okay, it's $6,000 a year. And the perception, way too expensive, costs too much, can't be bothered. I don't think these benefits are large enough. And the uptake, sacubitril/valsartan in the first year after a class 1 guideline recommendation was 2% in the US. So, it's narrow and rarely gets into clinical practice without substantial delay. We need to change this perception because, quite frankly, heart failure has a worse prognosis than most of the cancers with agents that cost $250,000 a year. To kind of highlight the magnitude of benefit with just going from ACE inhibitor, ARB, and beta blocker, that's the most common regimen still today for heart failure reduced EF. What would be the value? Switching to sacubitril/valsartan, adding the MRA, adding the SGLT2 inhibitor. And from this meta-regression analysis published in Lancet, you can see the relative risk reductions, but the key point of going from double to true optimized quadruple therapy extends heart failure with reduced EF patients' median survival by 6.3 years. So phenomenal life-extending benefit. Can we give all of the years lost due to heart failure back? No, but a substantial proportion should we apply. And this works in real-world practice. Here's data from Improve HF. You apply the guideline recommended therapies, you can get real-world improvement in 24 months survival. So if we contrast what's happened in clinical trials and clinical practice, this is profound. If you get in a randomized clinical trial for heart failure reduced EF now, you will have a 60, 70, 80% lower mortality rate than if you got in the early 1990s. What is the difference? To get in that trial, getting placebo in the new trial, you have to be on standard background guideline-directed medical therapy. By protocol, can't be randomized. Clinical practice in the same time frame, very little improvement in outcome. Why? Because the clinician can do whatever they want and patients get treated in a haphazard way. So we really need to take that protocolized approach and markedly improve outcome. So, the data for the magnitude of risk reduction, if you truly perceive that patient's risk, understand the magnitude of benefit, we'll try and as rapidly get foundational quadruple therapy on board. And if we do this optimally, nationwide, 100,000 additional lives per year could be saved. So to summarize, and sorry about the AV glitches, the benefits of heart failure reduced EF meds are additive incremental. There's no substantial overlap of any of these 4 key therapies that have been demonstrated. The optimal approach is using each of these medications. A serial or selective approach just leads to delays, not better tolerability, and events that could have been prevented with earlier use of GDMT not being prevented. There's high economic and clinical value, and importantly, we really need increased efforts of implementation in each and every clinical setting and for each and every patient. Thank you for your attention today.
Thank you so much, Gregg. After each of his lectures, then I feel sort of shame and go out and sort of review all my patient panels. But tell me, have you parsed the data into who is caring for the heart failure patients, internists, cardiologists, heart failures specialists, what the likelihood is?
Yeah, so we have, but I really want to convey that this is everyone outside of multidisciplinary heart failure experts working with advanced practice nurses. That if you look at cardiology practices, yeah, it's a little better than multi-specialty, a little better than pure primary care, but there's not much that difference there. So general cardiology and even some heart failure specialists that are focused more on other aspects of care and not GDMT optimization, there are these gaps. And so it really is ubiquitous. It's in settings where there's no cost barrier to meds, like the VA. So Paul Heidenreich and colleagues published there. It's in settings where you would think the patients are really highly affluent and there are no barriers. It's in, inpatient and outpatient settings. So it's really across the board. Yeah, we can find some associations where, there's a little greater likelihood and a little lesser likelihood, and there's disparities by age, race, and sex, but those are subtle relative to these huge treatment gaps.
Microphone. Thank you very much for a great talk. I just want to give a shout out to our county hospital, Harborview Medical Center, where our most vulnerable heart failure patients have the opportunity to follow up in clinic once a week in collaboration with our pharmacists and our nurse practitioners to up-titrate their GDMT. And I just want to say that, we have all this data that's supporting quad therapy for GDMT. At the end of the day, people, it's human nature, people aren't going to listen to the data. They're going to listen to the narrative that we have to tell them in relationship to the trust they have in the medical system. And as stewards of our profession, how can we navigate that dynamic when we tell someone that, we're going to start you on 4 GDMT drugs all at once or in rapid succession? How can we address those psychosocial dynamics so that our patients have trust in what we have to say?
So I've got to say, and it's so striking, for the hospitalized patient, and we're starting 4 meds, there's never a question. The question is the way we've been doing it the other way, which was, if this med was so important and life-saving, why didn't you start it right away? Why is it, 2 months later, you're now coming, oh, is this med brand new? Did it not exist before? And so we've created with our, well-intended, but very go slow and drawn out historic sequencing, this concept that conveys, whether directly conveyed or indirectly conveyed, this wasn't essential. You're adding this extra med. I must not have responded to the prior meds. Why aren't you replacing one of my existing meds? Somebody comes in with an acute MI that was on no prior meds. We have absolutely no problem. And with high rates, starting their in-hospital high-intensity statin, their ACE inhibitor, beta blocker, dual antiplatelet therapy. They were on no prior meds. They've had their ACS event. They're in hospital for 24 hours and happily go out on those meds. Why? These are these essential meds I need to be on. So some of it is, our own creation of these, scenarios that imply to the patient, whether overtly said or not, that things aren't working well or we're having to escalate and I'm getting worse. And so there's a lot that this rapid sequencer simultaneous addresses there. And yeah, the fine tuning and personalization of dosing can then take place. And why we're seeing you back quickly and necessary, it doesn't need to be in person. It could be potentially virtual or multidisciplinary, or even the pharmacist alone under standardized practices. So there's a lot we can do. I agree to change, the entire dynamic in that interface between patients, their caregivers, and the healthcare delivery system to be far more effective if that focus is on that key goal. And, a lot of the focus had been generic transition of care, or we've got to have the perfect diuretic regimen and alleviate congestion as if that's the key way to improve outcome. So it's part of it's getting that right target and understanding the timing in which we need to achieve that.
I have a question that, in the early on, you talked about systems of care. And I think, the issue of trying to convince us, we're all convinced, and talking about the individual physician provider or clinical provider of any sort, I don't think that gets us very far because, it's a systems issue. And so what are your ideas about how to influence our system so that these things happen basically once the patient's in the system, and what would our professional organizations be doing to facilitate that?
Yeah, so one is, you have to have that system functioning with the right algorithm or otherwise being perfect. And so part of it is getting those right algorithms. And so, the level of which clinicians may say, oh, we need all 4 of these meds, but how they actually go about that implementation is critical. Second is, you're absolutely right. You start, MRAs. You need to have reliance and belief that there's going to be follow-up potassium monitoring, having that reliable system. You want to have that follow-up if you're planning to do up titration outpatient, that patient's going to get that follow-up visit, be able to see, or you have the virtual outreach. So I showed it really quickly, but that was Implement HF, for 78 centers in 8 regions getting together to work on the system, utilizing the algorithm goal of quadruple therapy, and going from, an 8 or 10% quadruple therapy rate pre-intervention to 2 quarters later, 58%. So not perfect, but within 30 days and a discharge, these high rates, high persistence. And so I agree completely, it's a system approach, but it's got to be the system lined up to the evidence, lined up to clinical decision support, enough buy-in by the clinicians that they're not going to, the system saying this is what should be done. They're absolutely not. I'm not going to, one medication at a time. So we need, that complete and total academic detailing buy-in, but then also the multidisciplinary system, and then the tracking, reporting, and feedback. Is it actually working as planned? Are there unintended consequences? or are we, at our goals, or how we're going to further refine them?
I guess so asking each individual clinical practice or academic medical center or non-academic medical center to come up with their own system seems like a very slow way to do it.
So,
Why can't you just give us a system?
well, if I were anointed that power, I would do it. We clearly, get with the guidelines for in-hospital initiation, we're in 2,500 hospitals. We're trying to expand, implement HF after this pilot of 78 centers will be, rolling out nationally. There isn't a central control, and there may be good arguments about why there shouldn't be. But payers, if CMS were truly vested in outcomes, could provide incentives to move systems in that direction. The current kind of approach of financial penalties with HRP has not worked and hasn't been focused on getting patients on the right therapy, has been focused on, unintended side effects of upcoding and gaming of, readmissions into obstay. So I agree, in the ideal world or a truly national health system, you could have, systems put in place. Here, it's a little bit of volunteer effort and convincing enough people and stakeholders to really recognize the importance, the urgency, and actually implement.
Seems like it's time for an editorial in Heart.
Well, I don't know, maybe we should stop trying to convince individual medical centers and convince Google or Microsoft or Amazon.
All right, on that note, I'd like to thank Gregg. I would also like to encourage you, he is giving medicine grand rounds today, which is also online. So please, if you have time, Zoom into that. And thank you so much, Gregg, for being the visiting Samson lecturer today.